Hi guys, welcome back. The current topic of dyselectrolytemia is one of the frequently asked topics in whether you sit for a USMLE exam or PLAB or any Indian exam like NEET PG, FMG or next. So let's do a deep dive into this topic, and I'll start with hyponatremia. That would be the first one, and the reason for that will become very obvious to you when I write down the following question. This is a previous year question that simply said which is overall very straightforward one, though the question said which is the most common electrolyte imbalance that is going to be encountered in hospitalized patients. Now, I'll tell you the reason also, that why is it that this happens to be the commonest electrolyte imbalance in hospitalized patients. For that, I'll tell you a formula also, mathematical one, to give you a mathematical justification. But once we know that this happens to be the commonest electrolyte imbalance, I'm not going to tell you about a formula with respect to plasma osmolality. In fact, at this juncture, I can also say a physiology-based question that simply said which is the most important determinant for determining plasma osmolality. Well, your answer would be given as sodium. And this formula is what you would have studied even in your first year. That is 2 times the value of sodium and potassium. To this, you need to add then blood urea nitrogen, which would be divided by 2.8. And to this, you'll be adding up the glucose concentration in the blood in milligram per deciliter, which would be divided by 18. If you look at the mathematics here, you can see that you are multiplying sodium value by 2. So overall, I can say that the most important determinant for plasma osmolality happens to be sodium. And because this is a major determinant, if sodium will become either lesser or will become more, I can use the term dangerous hyponatremia and dangerous hypernatremia. For the term dangerous hyponatremia, I would say the values would be less than 125. Dangerous hypernatremia would be values in excess of 158 millicoulombs. Normally, 135 to 145. So the values that I've said, and I'll write down the values subsequently when I come to the discussion as well, would result in development of seizures. And why seizures? Because there would be cerebral edema in the patient, and normal values of plasma osmolality would be ranging between, again, there can be slight disparity in values. Like in some books, it is given 285 to 295 milliosmoles. In some books, it is a little slightly lower range, that is 275 to 295 milliosmoles. So don't really bother about it, because I can say that most of the time the laboratories could be having slight variations with respect to the normal values. But in case you get a report which is less than 265, or you get a report more than 320, which would parallel the sodium value. Sodium is going to be lesser, the plasma osmolality would be lesser, vice versa. Any values less than 265 or values more than 320 are bound to cause problems for the patient. And as I said, what is dangerous hyponatremia? Then your answer is that would be severe hyponatremia. Mild would be in the range of about 130 to 134. Then you keep on decreasing, right? In a range of 126 to 130, that would be moderate. Anything less than 125 would be called as severe hyponatremia. And because there would be cerebral edema coming up, therefore seizures can develop in a patient. Even if you are going to be giving diazepam, benzodiazepines to these patients, you might be able to get a transitory control over the convulsion component. But unless and until this dangerous hyponatremia is corrected, we would not have resolution. So a lot of these patients can land up in even a status epilepticus state. Once you get the critical values right, my next objective would be to tell you that I'll be describing various subtypes of hyponatremia and the causes that they love to ask in the exam. And first on the agenda would be this terminology that is that's self-explanatory, hypotonic hyponatremia. The meaning of this term would be hypotonic would mean that the plasma osmolality of the patient would be lesser than the cutoff values that has been taught to you. That is a lower limit of in a range of 275 to 285. So once the values go lesser than this, what are going to be the causes that's going to contribute to this is one of the main reasons why we are studying this topic. So I'll start with relatively easier one to comprehend. Let's assume a person is suffering from diarrhea or vomiting. In either of the two situations, there would be loss of water from the body as well as loss of salt from the body. So because of the fact that both the things, that is water is also less and salt is also less, with respect to diarrhea or vomiting, the technical term that I would like to put up now would be hypovolemic, because anyway diarrhea would contribute to a decrease in the circulating fluid volume of the patient due to volume depletion. So the term coming up is hypovolemic hyponatremia. This is one of the varieties of the topic of hypotonic hyponatremia that I'm explaining to you. And well, what would you do in this case? You'll give either ORS or you'll give IV fluids to the patient. Like in diarrhea, you'll be giving ringer lactate. In vomiting, you'll be giving normal saline. Yes, normal saline in vomiting, because vomiting causes metabolic alkalosis. And yeah, I am going to explain to you subsequently how does that happen. But at the moment, do remember the preferred fluid to be used in a diarrhea patient is ringer lactate. You know that anyway. For vomiting, do not answer ringer lactate. Your first answer would be normal saline, and more explanation for this is going to follow as we progress in the discussion. Now let us assume a patient is suffering from syndrome of inappropriate ADH secretion. Once the values of ADH will spike, they are going to cause an extra stimulation of the V2 receptor. And this extra stimulation of V2 receptor is going to cause more reabsorption of water. So what's going to happen in this patient is the total body water will increase, but total body salt is not going to change. So if you look at this from the mathematical perspective, I said water in the body is more because antidiuretic hormone drives water. Water is more, but the salt is normal. So therefore, there would be some dilutional component coming in, which will explain the hyponatremia. And the technical term that I would like to now incorporate on the slide would be euvolemic hyponatremia. A lot of people get influenced by English here and they think that euvolemia means, the word euvolemia means that water in the body is normal. No guys, that is not the case. Euvolemic does not mean that water in the body is normal. It means that the water in the body is more. But the salt amount is normal, so the dilutional component would come up. I mean, if you look at it from mathematics, if you just focus on the word sodium concentration, if I say sodium concentration, that means sodium divided by water in the body. If the water in the body is in excess, volume expansion, that's when the sodium values would reduce. And in a lot of questions, he might deliberately not write SIADH, but he would write causes of SIADH. And surprisingly, one of the leading causes of development of SIADH would not be answered as a hypothalamic tumor. You know, antidiuretic hormone is released from the posterior pituitary, but where is it produced? Hypothalamus. But yeah, I mean, I agree that hypothalamic tumor can contribute to a SIADH, but the leading cause for development of this would be cerebral toxoplasmosis. And therefore, the question will begin with the AIDS positive patient who's having recurrent episodes of seizures, and a CT has shown an intracranial space occupying lesion. I mean, look at the deviation that he'll try to put up. This question will begin by describing a AIDS positive patient who is having an intracranial space occupying lesion and is having recurrent episodes of seizures. Well, there are two reasons why this person is having seizure. One, anytime if you have an intracranial space occupying lesion due to cerebral toxoplasmosis, the person is bound to have development of seizures. Plus, this is also going to cause excessive release of, or it would cause gain of water, and the water gain would be disproportionate to the amount of salt. So therefore, euvolemic hyponatremia would set up in the patient. Another important reason that can be asked is again an infectious cause. Shockingly but true. I mean, even in the topic of pneumonia, I have spoken about it. Even in the recently concluded January 2022 FMG exam, they put it up, 23 exam, in fact, they put it up. That is Legionella pneumophila. Why Legionella pneumophila is said to cause, I mean, the term used is atypical pneumonia. Why are you using the word atypical is because of the fact that this pneumonia is causing person to develop seizures. I mean, traditionally, if a pneumonia person will have seizures, you will think, okay, man, hypoxia might have contributed to it. But no, it's not hypoxia. It's electrolyte imbalance. So the question specifically mentioned in the exam that a pneumonia patient is found to have hyponatremia. Sodium values were given in the range of about maybe 124, maybe 123 milliequivalents. And he said what could be the reason behind it, which organism could be responsible for causing this presentation of pneumonia where person is having hyponatremia. Then this organism is to be remembered by you, that is Legionella pneumophila. Other causes of SIADH, though SIADH is discussed even in the second video, that's just the video after this, where I've spoken about Bartter syndrome, Gitelman syndrome, diseases of the kidney tubules. I have talked about SIADH also, but since I'm getting an opportunity once again, why not discuss about it? Brain abscess, meningitis. So the message is central nervous system infections can contribute to development of manifestations like SIADH. And then the point number 4 is again plausibly, or I think liable to be asked, because he can talk about the most aggressive lung cancer. You know that lung cancer can cause paraneoplastic manifestations. So the cells of oat cell cancer, small cell cancer, can produce excess amount of antidiuretic hormone that will cause more water to be gained, and therefore euvolemic hyponatremia can cause seizures in this AIDS positive patient. The description given in the question would be is a diagnosed case of small cell cancer. He's not been feeling well for last 1 week. He's having headache, he's having disorientation, and today morning he ended up with a couple of episodes of seizures, was rushed into your hospital. Why would a lung cancer patient develop seizures? One could be metastasis to the brain. Or instead of metastasis to the brain, it could be electrolyte imbalance also, thanks to the excessive amount of antidiuretic hormone which this tumor is producing. Another ectopic source that I would like to mention is carcinoid tumor. Point number 4 that I've taught you is also going to be capable of synthesizing excess amount of ACTH. So there is a probability of causing Cushing syndrome. But Cushing syndrome does not contribute to euvolemic hyponatremia. It is excessive production of antidiuretic hormone in this case. So ectopic ADH production is the villain in this case, which is contributing to the manifestations in this person. At this junction, there would be a doubt brewing up in your mind that, sir, why is it that a pneumonia patient is having SIADH-like manifestations, or AIDS positive patient with cerebral toxoplasmosis is having it? So all these CNS conditions are contributing to, especially point number 1 to point number 3. The technical term that is used for point number 1, 2, and 3 in the textbook is reset osmostat. The meaning of the word reset osmostat is that antidiuretic hormone production threshold is reduced. You see, there is a particular level at which our body will respond by producing various hormones. Like if you have a water depletion is bound to cause excessive reduction of aldosterone and antidiuretic hormone. So there's a certain critical threshold. I mean, if you lose substantial amount of water from the body, that is when you would be having development of stimulus for release of aldosterone and antidiuretic hormone. Here, this threshold, ACTH production threshold, is substantially reduced. That, let me say, meningitis patient would be having vomiting also. Raised ICP contributes to vomiting, projectile vomiting for that matter of fact. So what I'm trying to tell you is that the threshold for release of antidiuretic hormone is reduced. So there's an excess of antidiuretic hormone. The check mechanisms are not working properly because of these CNS issues. The control over the release of antidiuretic hormone is hampered. That's the meaning of the word reset osmostat. I repeat that again. Meaning of the word reset osmostat is the check mechanism, the normal functioning of antidiuretic hormone release per se. That control is not there because of the CNS issues or due to a lung infection occurring in a person. And that is why you have a condition of excess water in the body contributing to euvolemic hyponatremia. So what I have done on this slide is, guys, I've given you 2 reasons why a person could be having a hypotonic hyponatremia. In fact, the information which is given on the current slide at the moment are the 2 subtypes. I mean, as far as the first one is concerned, hypovolemic hyponatremia, nobody has a problem understanding that because that's very simple, straightforward English. From the exam perspective, I want you to mainly remember for this slide, the key word is euvolemic hyponatremia. What I want to be imprinted into your brain is the following words: cerebral toxoplasmosis, Legionella pneumophila, brain infections. It could be, instead of meningitis, encephalitis, brain abscess, and then even ectopic antidiuretic hormone production. These are causes for development of euvolemic hyponatremia, which does not mean that there is normal water in the body. It means that there is excessive water in the body. Now for the next subset of cause of hyponatremia, I'll give you a shorter description. I want you to listen to this before you note it down. Let's assume a cirrhotic patient is having ascites, maybe I can say massive ascites. And I want you to compare a ascites patient with yourself and tell me on a comparison basis that what's going to be the effective circulating fluid volume of a normal person versus that of a person with ascites. You see, in this chap, the fluid is wasted in the peritoneal cavity. I mean, in us, there's no, in male or female, normally there is no fluid in the peritoneal cavity. I mean, okay, in females, they could be up to 5 to 10 ml at the time of Mittelschimmers, that is mid-cycle, but otherwise there's no fluid in the peritoneal cavity in a male or female routinely. And this person is having wastage of fluid in the peritoneal cavity. This fluid should be in the blood vessels. So, because I said casually the word wastage of fluid in the peritoneal cavity, so the effective circulating fluid volume of an ascites patient would be lesser. Because of the circulating fluid volume is lesser, the blood supply to the kidney would also be lesser. So GFR will reduce. This is gonna provide a positive stimulus to the RAS and would drive up the values of aldosterone. So learning number 1 from the current discussion on the slide implies that ascites is a condition responsible for secondary hyperaldosteronism. Just like you guys are comfortable with the fact that primary hyperaldosteronism can be either due to bilateral adrenal hyperplasia or due to adrenal adenoma like Conn syndrome. The term Conn syndrome is specific for adrenal tumor. And if you have a bilateral adrenal hyperplasia, that would be primary hyperaldosteronism. But ascites is because of all the physiological conditions I said, wastage of fluid in the peritoneal cavity, lesser circulating fluid volume, stimulation for RAS. This is an example of secondary hyperaldosteronism. Now look at how aldosterone acts. This would be acting on a receptor by the name of ENaC. The name of the receptor is epithelial sodium channel, and look at what it does. It would be responsible for gain of salt and water. That's okay. I mean, understandable that aldosterone is responsible for gain of salt and water, and this also explains why to people with ascites, people with liver damage, we tell them to eat less amount of salt, but there will also be a correspondingly exaggerated urinary loss of potassium and hydrogen. I said if there is an increase of aldosterone in the body of a person, then there would be an exaggerated urinary loss of potassium, as well as, you see the way I have modulated the arrows. I'm trying to say here before you that, okay, I mean, more salt and more water is coming in, that will worsen the ascites of the patient. So I was telling this guy, sir, eat less amount of salt. Patient is not going to listen to me, so his ascites will worsen. But the corresponding urinary loss of specifically the potassium and the hydrogen in this patient will also experience at the same time hypokalemic alkalosis that develops in these patients. Let's look at the data that I said. I said aldosterone is causing gain of water. You saw the arrow that went up. And at the same time, it is also causing a gain of salt also, because after all, the function of aldosterone is gain of salt and water. You all know that from your first year. But look at what I did here. I put up 2 arrows for water and 1 arrow for salt to say that still the water in the body is disproportionately increased as compared to that of the salt, because of which the term that I'm introducing now at the moment is hypervolemic hyponatremia. Every time you're going to read this term hypervolemic hyponatremia, I want you to have a reflex going in your brain that every time you read this term, it implies aldosterone in the body is more. I have put up 2 arrows for water, a single arrow for salt to sensitize you to the fact that because of the dilutional effect coming up, I've used the word hyponatremia. But the most important point that I want to emphasize once again is every time you read the word euvolemic hyponatremia, which hormone is coming into picture? Antidiuretic hormone. And if you read the word hypervolemic hyponatremia, the hormone coming in the picture would be aldosterone, because obviously aldosterone causes gain of both water as well as salt. So hypervolemia meaning is both water and the salt in the body is more. That's a separate issue, that the amount of water is disproportionate to that of salt. Over and above this, you can also understand that these patients would be having urinary loss of potassium. So I am writing hypokalemic, and because of exaggerated urinary loss of hydrogen also, these patients would be having is metabolic alkalosis. So that's itself a question. Ascites patients develop metabolic acidosis, alkalosis, respiratory acidosis, alkalosis. So you saw here exaggerated urinary loss of hydrogen will explain the alkalosis component present in these patients. I'll be putting these patients on a salt restricted diet. I tell this person, sir, don't add salt to your diet at all or keep it minimal. And at the same time, spironolactone has to be given. And if ascites tends to deteriorate into massive ascites, we might have to plan even a large volume paracentesis in these patients. The description on this particular slide mainly caters to increase of aldosterone. That is this particular terminology that I've said, which is going to be hypervolemic hyponatremia. And in an exam, what he can do is, I mean, he may not deliberately write the term ascites. What the examiner can do is he can write down a couple of causes of development of ascites, because this could be written as cirrhosis. It could be written as nephrotic syndrome. He can then say congestive heart failure. Or he can say constrictive pericarditis, because if you listen to my discussion of constrictive, there's a calcification around the right as well as the left side of the heart. If you have a calcium deposition around the right heart, then the poor fellow, the right ventricle which is calcified, would not be able to dilate and relax. Therefore, the filling of blood in the right side of the heart is compromised, and therefore ascites could be developing in these patients. So cirrhosis, nephrotic, congestive heart failure, constrictive pericarditis, these are a couple of terminologies that an examiner might be using instead of ascites to describe what I've said, hypervolemic hyponatremia, or just focus on the English word congestive heart failure. I mean, the heart is not working properly. There's a decrease of GFR. RAS system is once again stimulated. Once RAS is stimulated, which hormone increases? Aldosterone. And just sensitize you to the fact, if antidiuretic hormone is more, your answer is euvolemic hyponatremia. If aldosterone is increased in the body, then it is a hypervolemic hyponatremia developing in the case. To see whether you've understood me or not, I'm now gonna give you a short description. So even if you're noting it or you're having printed notes, just keep everything aside and listen to my next words very carefully. Let's assume a person is suffering from subarachnoid hemorrhage. This can occur either due to trauma or due to rupture of berry aneurysm, with trauma being a relatively more common cause. Now, because of this subarachnoid hemorrhage, this particular person is having the most excruciating headache of his life. Worst headache of my life is a very common description that is given in multiple choice questions on this topic. And every time you have subarachnoid hemorrhage, the ventricles of the brain, right, we're talking about brain at the moment, would be producing B-type natriuretic peptide. Now, when I talk about BNP, BNP is also produced from the ventricles of the heart in congestive heart failure. But at the moment, I'm talking about ventricles of the brain coming into the picture. And if you just go by English, BNP, once it increases, is going to cause natriuresis in a person. Because of this natriuresis, because there would be salt loss from the body, there will be corresponding salt and water always go together. If there's going to be salt kicked out of the body, then water will also be lost, and therefore total body water and total body salt both would be reduced. Therefore, the term that I'll use to describe this is hypovolemic. Why? Because there is a water loss from the body and simultaneously a salt loss from the body also. This would be hypovolemic hyponatremia. Well, the question for you guys is, everything that I put in this box, what's the technical term for it without looking at the notes? The technical term for this would be cerebral salt wasting syndrome. So what I've done at the moment is added more knowledge to your existing database that cerebral salt wasting syndrome should be also answered as an example of hypovolemic hyponatremia. The important statement is, I'll repeat that again, cerebral salt wasting syndrome is also an example of hypovolemic hyponatremia. And anyway, people with subarachnoid hemorrhage can die, they can succumb not because of bleeding, not because of electrolyte imbalance. The usual reason of death in subarachnoid hemorrhage should be answered by you as brain infarction. Bleeding in subarachnoid hemorrhage is very limited. It's not the bleed that will cause the death. I mean, it will contribute to problems. Agree to that. Electrolyte imbalance will contribute to problems. But don't even answer raise ICP. Answer it as brain infarction, because whenever there is a bleed, the surrounding area undergoes a spasm. I thought I should mention this here because they'll give you a profile like this and then say what would be the probable reason of mortality in cerebral salt wasting syndrome. The first thought process is saying salt wasting, so I should answer hyponatremia, but that's not the case. The leading cause of death in these patients initially would be a brain infarction, because after all, there's a bleed in the sylvian fissure of these patients. Now, once we get this data right, we need to summarize this and get the data imprinted into our brain. So this is what I started with. The broader term that I taught you was hypotonic hyponatremia, which means that the plasma osmolality would be lesser than the lower limit that I told you, which was in the range of about 275. Now, when it comes to hypotonic hyponatremia, we'll make 3 arrows like this. I would suggest you to do it by yourself so that you can get the data right. That is, there are 3 varieties of hypotonic hyponatremia. That would be hypovolemic, then is gonna be euvolemic hyponatremia, and the third one is hypervolemic. Though this has been discussed, we are just trying to re-emphasize and reorient the data in our brain. The description to be remembered by you is like this. If you read the term hypovolemic hyponatremia, your thought process is, okay, both arrows are going down. But if you read the term euvolemic hyponatremia, it means that total body water is increased, total body salt is normal, so there's a disparity. And with hypervolemic one, you can see that both are increased, but I put a single arrow with respect to single arrow with respect to salt to say that water is disproportionate. That's why the hyponatremia component can be understood here. Now let's jot down the causes here as well so that we can just remember them. The simplest example for the left hand side would be volume depletion with respect to diarrhea and vomiting. And because this is very simple and straightforward, he might describe a patient of Crohn's disease. Now, Crohn's disease patients could end up with the enterocutaneous fistula, and this enterocutaneous fistula could again explain, loss of water as well as electrolytes from the body. Or for that matter of fact, I told you regarding cerebral salt wasting syndrome. So the examples which I want you to remember at the moment would be fistula, cerebral salt wasting syndrome among the ones, and then excessive use of diuretics. Suppose a person is having congestive heart failure, the doctor has given excessive amount of diuretics, or it's a CKD patient and the doctor has given excess amount of diuretics disproportionate to, whatever water that is consuming is fine, but at the same time, because you have given more diuretics, there would be a volume depletion. And as such, I can say that diuretics are supposed to lose both salt and water. That's how they work, right? Furosemide, thiazide, they work by causing loss of both salt and water from the body. So hypovolemic hyponatremia could be understood. When it comes to euvolemic, the most important point to be remembered is syndrome of inappropriate ADH secretion. There were two aspects that I've already explained to you: cerebral toxoplasmosis and Legionella pneumophila. Though I've gone even beyond this, I've given you 4 examples, but 2 that is must know for you at this junction would be cerebral toxoplasmosis and Legionella pneumophila, the causative organism for atypical pneumonia, and we use macrolides for its management. Now, coming to the second cause, we have a post-operative patient who's having euvolemic hyponatremia. And why does it happen? Then there are 2 explanations that I can give you. One is that when you have given anesthesia to anybody, anesthetic drugs, you would have seen patients in the recovery that when they come out of anesthesia, they tend to vomit. So nausea and vomiting are causing a fluid loss from the body, and as a result of it, antidiuretic hormone would be increased. And at this juncture, a lot of students, they just interrupt me and they say, doctor, you said vomiting causes hypovolemic hyponatremia. Why would not a post-operative patient also end up with then a hypovolemic hyponatremia? Well, the logic here is that because he's in the hospital, because he's admitted in the hospital, we also give, because we know that this will happen, what we do is we usually tend to give a liberal amount of IV fluids to post-operative patients. And when you give lots of fluid to these patients, then lots of fluid would expand the total body water component and would contribute to euvolemic hyponatremia. We know he will vomit. There are going to be losses. Compensatory antidiuretic hormone will work. That is okay. But over and above this, we are very liberal with fluid administration post-operatively, primarily because we want to prevent dehydration in the patient. But instead of preventing dehydration, we have prevented dehydration, that's okay. We might actually end up overhydrating the patient, and that can trigger a euvolemic hyponatremia. The next example is that of endurance sports. Like this individual is a marathon runner. This marathon running would involve running 42 kilometers. It's not a joke in a country like India where it's so hot. A person has to run for 42 kilometers, or forget about marathon, half marathon, 21 kilometers itself, it will require a lot of physical stamina. So this person is bound to lose salt and water from the body. Now, when these athletes are running, you would notice that they keep on drinking energy drinks also. These energy drinks, lots of time, they might take energy drinks before the competition also, in between the race also, they might take a bit of energy drink. And that energy drink would be having salt. By energy drink, I mean here that it would be primarily having salt, electrolytes, which would be replenished. But if during endurance sports or before endurance sports, if a person is consuming excess amount of water, then this can again cause increase in total body water and can contribute to a euvolemic hyponatremia. Coming to the fourth one after endurance sports would be, this is an American patient. Like in India, people tend to take mainly vodka and whiskey, but this is an American or an Australian patient. And when he gets up in the morning, the first thing that is gets up and what he does is he opens his refrigerator and he drinks beer. So compulsive beer drinking. This guy is having alcohol addiction. He is having compulsive beer drinking. That would be called as beer potomania. That would again explain expansion of plasma volume. Six-pack beer is consuming on a regular basis. Expansion of total body water would occur, and again euvolemic hyponatremia will occur. When it comes to the fifth cause that I'm writing here before you, this is the one which is most likely to be forgotten. Rest is understandable. Post-operative excess amount of water given to the patient, rehydration done in excess. Endurance sports, he is not having access to those energy drinks, but is rather taking plain water in excess, beer potomania. But hypothyroidism, I mean, the first thought process is, sir, how is it possible? Thyroid hormone, we read thyroid hormone is for basal metabolic rate. Thyroid hormone is for calorie genesis. In children, it also brain myelination, and you are saying it can cause electrolyte imbalance. So let me just give an explanation for it, because I'm a little short on this slide space, so I'll just move it up. And what I want to tell you is that thyroid hormones also, they tend to regulate the release of anti-diuretic hormone. In fact, T4 has also been shown, T4 and ultimately T3, they also tend to regulate anti-diuretic hormone release. What I mean by this regulation is inhibitory control. Just like our brain has an inhibitory control over the muscles, similarly, thyroid hormones tend to have an inhibitory control over the release of anti-diuretic hormone. And if these hormones will become less, then inhibitory control will be lost. If you lose inhibitory control, then antidiuretic hormone levels will increase, and that would explain why a person of hypothyroidism could be having a development of SIADH-like manifestations and euvolemic hyponatremia. I'll try to explain this once again to you, and I'll put up another example here. This patient of mine is having secondary hypoaldosteronism. When I say primary hypoaldosteronism, I mean Addison disease. Like you're aware that Addison disease, which I've described with the example of Osama bin Laden, the chief of Al-Qaeda responsible for 9/11, he was suffering from primary Addison disease, and he was having decrease in aldosterone, cortisol, sex steroid values. But currently on the slide is the term secondary hypoaldosteronism. In secondary hypoaldosteronism, the hormone which is going to be hampered is cortisol, and then cortisol also does the same thing. Cortisol also does a regulation of ADH release. It also has an inhibitory control. The key word is that even this hormone is responsible for inhibitory control of antidiuretic hormone release per se. And if you are going to have a hypocortisolism, I repeat that again, if you are having a decreased values of cortisol, then there would be a loss of inhibitory control, and this loss of inhibitory control will explain that the person would start having an increased level of antidiuretic hormone and would contribute to a euvolemic hyponatremia. So from hardcore endocrine perspective, hardcore kidney perspective, I want you to remember, standard causes are understandable, but 5 and 6, the 6th one is what I'm jotting down once again here before you. This would be a person having secondary hypoaldosteronism. This implies that there is decreased production of cortisol. We are not talking about primary Addison disease. I repeat that again. We're talking about secondary hypoaldosteronism, and this would explain why the person would be having, because cortisol and thyroid hormone, the learning point is that cortisol and thyroid hormone both contribute to control on the release of antidiuretic hormone, and thereby can contribute to development of euvolemic hyponatremia. As far as the extreme right hand side are concerned, he's gonna write conditions before you where you have ascites. Ascites can be seen with cirrhosis because albumin is lesser. It can be seen with congestive heart failure. Patients on nephrotic syndrome also, because nephrotic would be having albuminuria. There would be a urinary loss of albumin, which will explain the fact that why these patients can be ending up with development of ascites. Then even parenchymal disease of the kidney, like suppose person is having acute kidney injury due to toxins, ethylene glycol poisoning, or any toxin. Toxin could be like rhabdomyolysis, it could be hemoglobin in black water fever. The tubules are getting blocked by either myoglobin or by hemoglobin, and there's a tubular necrosis, and the kidneys are shutting down, man. The GFR is going to be less, RAS is going to be activated, aldosterone will go up. Remember what I told you, for the extreme right hand side, I said aldosterone is the one which is the villain, whereas in the middle it was antidiuretic hormone that was coming up. So he can describe any parenchymal disease of the kidney before you, like acute kidney injury, or he could write chronic kidney disease, like leading cause of chronic kidney disease, diabetic nephropathy, or chronic glomerulonephritis. All the types of glomerulonephritis that you read, RPGN, or crescentric glomerulonephritis. Ultimately, if the GFR will fall, RAS will be stimulated, aldosterone values would go up, and both aldosterone is going to cause both salt and water to increase, but there would be excessive water as compared to salt. So that is why the term is hypervolemic hyponatremia. Most of the time in the exam, whenever hyponatremia is asked, they are going to ask you this table, and in this table, in majority of situations, he might put up a patient of lung cancer who's not been well, patient is having headache, disorientation, and then ends up with development of dangerous hyponatremia as well. Or he could give you a Legionella pneumophila patient, he has suffered from pneumonia, he is having bilateral lung infiltrates, and simultaneously the electrolytes of the patient have been incidentally found to be lesser, and person ended up with a seizure. We thought it is hypoxia causing seizures, and we put up a pulse oximeter. Yeah, oxygen saturation was low, but it was not like, danger like 50, 60. It was like the oxygen saturation of 90%. Because in pneumonia, we are bound to have our oxygen saturation to be lower, but this chap was having an electrolyte imbalance contributing to this. So SIADH is to be considered primarily as one of the important ones, or he could begin with a distraction, to the max level. AIDS positive patient, a CT scan is showing intracranial calcification in area of basal ganglia. It has been found that a person is suffering from he is going to describe that, term like cerebral toxoplasmosis may or may not be given. He might say AIDS positive patient, recurrent episodes of seizures and calcification around the area where the basal ganglia is present. So once he says all those things, it's a deliberate ploy on the part of the examiner to distract you, and you are smart chaps, you would not get distracted because of the fact that you would be able to answer all of this. And more importantly, you will also be able to, in some of those two-step questions, answer in the following fashion that I say next. If it says, how do you handle euvolemic hyponatremia? I'll write it on a separate slide, but let's just do a simple discussion here. In euvolemic hyponatremia, antidiuretic hormone is in excess. So to block the excess of antidiuretic hormone, I can be giving vaptans to the patient, molecules, tolvaptan, conivaptan. So vaptans will be one of the approaches that would be highly effective in the euvolemic variety. But with respect to the first one, I don't need to give any vaptans. I will just give ORS, IV fluids to the patient. But can you ever give IV fluids to patient of heart failure? No, it's going to cause worsening of pulmonary edema. Can you give IV fluids to a person with nephrotic syndrome? Is all ballooned up. No, nephrotic would be having periorbital edema, pedal edema. You'll not give IV fluids. What are you going to do on the extreme right hand side? You are going to give diuretics to these patients. Heart failure, we give diuretics. Kidney injury, acute kidney injury, we give furosemide bolus and a furosemide drip. In cirrhosis, we give spironolactone. So the answer to the variety of hyponatremia asked to you in the exam will vary based on whichever variety of hyponatremia is asked to you. And because of the fact that if I write on the same slide, it will make it a little clumsy. So what I'll do next is just jot down the treatment parts once again. You see guys, I've explained to you treatment with respect to hypovolemic hyponatremia. Your first answer would be that wherever oral intake is possible, we'll give ORS to the patient. If it is cholera, diarrhea, I will give ringer lactate to the patient. If it is vomiting in the patient, then I'll be giving normal saline. So IV fluids, that is crystalloids, would be given to any patient having hypovolemic hyponatremia. Now let us compare this with a person having euvolemic hyponatremia. By this time, I'm very sure all of you have developed that reflex. Every time euvolemic hyponatremia, SIADH. What's going on in your brain? Lung cancer, ectopic production, reset osmostat like Legionella pneumophila or brain abscess. So in euvolemic hyponatremia, the first thing you will answer is fluid restriction. Obviously, because if the total body water is more, then I'll like to go in for fluid restriction. And I would also like to give vaptans to the patient like tolvaptan, for example, so that I can counteract the excess. At least whatever has happened has happened. But if I block V2 now, I will be able to prevent the reabsorption of water coming in. That's why the term was euvolemic hyponatremia. The third one on the agenda is hypervolemic hyponatremia. This is due to expansion of plasma volume. This time I'm saying the word plasma volume because I'm talking about both water and salt coming up. So in this case, the first thing is any heart failure patient, any acute injury patient, we need to go for fluid restriction. Guys, if you're paying attention, when I started, I said for hypovolemic hyponatremia, liberal amount of fluids need to be given. But for the inferior to variety, you are not gonna give IV fluids to the person. Person would be put nil orally by mouth. In heart failure, kidney injury, we don't give anything to the patient. We need to do strict input-output monitoring, and we'll also be using diuretics in the patient. The choice of diuretic can vary. In acute kidney injury, furosemide. In chronic kidney injury, we tend to use metazolone or thiazide group of diuretics. In ascites, we tend to use spironolactone. So the choice of diuretic can vary, agreed. But then, you need to answer treatment of hyponatremia based on the etiology that has been given to you. Additional fact that I would just like to add to this table now is that they can also ask you how would you try and differentiate between, let us say, diarrhea or fistula patient versus cerebral salt wasting syndrome. So the test you can do is urinary sodium. You see, in a diarrhea patient, because there is a volume depletion, the kidney will try to reabsorb all of the water as well as the sodium, so urinary sodium will be low. But if you are using excess amount of diuretics, how do they act? They prevent absorption of salt and water. Cerebral salt wasting syndrome, BNP, is causing natriuresis. Natriuresis means sodium is being lost. So the inferior two conditions would be having is an increased amount of urinary sodium. So urinary sodium can help you identify which of the following could be a possible etiology. Like the three options in the question could be diarrhea, vomiting, fistula. Fourth one could be cerebral salt wasting syndrome. And you might simply say a straightforward question: urinary sodium is higher in. You just need to use English. Cerebral salt wasting, right? The word is salt wasting, so urinary sodium would be elevated. Whereas in the top three conditions, the kidneys will try to conserve the electrolytes, conserve the water, and that is why the urinary sodium of the patient would be lesser. I would like to rate this particular slide as the most important slide of the first, I would say, 30 to 45 minutes of this particular video. I mean, every word that I've written here should be imprinted with special emphasis in the middle of the table on point number 1, point number 5, and point number 6, where I told you thyroid and cortisol have an inhibitory control over the release of antidiuretic hormone. I've emphasized these points multiple times so that I could make an impression and ensure that you don't have to revise this topic. I want you to listen to this one read, and I want you to be capable of striking the questions right. Next up, I'll be telling you regarding hypertonic variety of hyponatremia, which would mean that the plasma osmolality of the patient would be in excess of the limits that I told you. And why would this happen? Then the first example of hypertonic hyponatremia would be that this person is having very high blood sugar values of something like 500, 600 milligram percent, 6x of normal. Where would this be happening? This is a patient of type 2 diabetes mellitus. He's suffering from hyperosmolar coma. Hyperosmolar coma, incidence wise, you will notice is more common with type 2 diabetes, whereas diabetic ketoacidosis is more common with type 1. That does not mean that diabetic ketoacidosis can't happen with type 2, and it does not also mean that hyperosmolar coma cannot occur in type 1. But I just told you incidence wise data, the DK is more common with type 1, hyperosmolar coma with type 2. And when you have such a large amount of sugar present in the blood, then this sugar will create a solvent drag. This solvent drag will cause two things. One, because it's drawing in water into the circulation, this will contribute to dilutional aspect coming up, and the sodium values will begin to fall. In fact, the basic aspect for point number 1 that I wanted to remember is that sugar and sodium values, they always show an inverse relation, that when the sugar in the blood will rise, sodium will be lesser. That means hyperosmolar coma, hyponatremia would be present. Vice versa, when the sugar will tend to go back towards normal, or in fact lesser than normal, then the sodium values will be on the higher side. And the mathematical input that I wanted to remember at the moment is that if the sugar in the blood rises by 100 milliequivalents, then the sodium begins to fall. Though in Harrison at two different places he has mentioned two different values, I would like you to remember what I am telling you at the moment, which is that if the sugar rises by 100 milliequivalents, then the sodium will begin to fall by 1.6 milliequivalents. So there's an inverse relation which is to be remembered. Apart from hyperosmolar coma, another can be mannitol. You see, mannitol per se is itself a hypertonic compound, so because it will draw in water, again the concept is still the same. Solvent drag is a common entity that would be valid for all the conditions that I'm writing here. There are three reasons why I'm explaining to you that they can be a hypertonic hyponatremia. That would be radio contrast, mannitol, and hyperosmolar coma. The common thing in all of them is solvent drag, which explains the hyponatremia component, because water would come in and will cause a dilution. Plus this mathematical parameter should be remembered. 100-point increase for sugar, the sodium values will decrease by 1.6. And now we are going to compare this with one which is least likely to be asked out of the three varieties. I started with hypotonic, then was hypertonic, now it's going to be isotonic hyponatremia. Well, a lot of time this terminology may also not be given in questions. Isotonic hyponatremia, he might use an alternative term, that is pseudo hyponatremia. And now let me explain to you what he means by the word pseudo hyponatremia. Let us assume that this person is suffering from familial hypercholesterolemia, which is one of the common autosomal dominant lipid profile disorders. And because the person would be having very high values of cholesterol and triglycerides, then this cholesterol and triglyceride in excess can interfere with the measurement with respect to sodium. Similarly, I can say if a person is having excess amount of paraproteins, you see normally the protein in our body would be like albumin, globulin, fibrinogen, but I am describing positively charged proteins, that is paraprotein in the circulation. The paraprotein that I'm talking about at the moment would be multiple myeloma, the Benston's proteins. We are having a light chain defect, there is overproduction of defective antibodies. So if we are having paraproteins in excess, then this again contributes to interference with the measurement of sodium. The kits which are used for, or the methods which are used for estimation of sodium, can actually be showing a falsely low reading, though actually sodium in the body is normal. It is just the fact that the values are coming up to lower because of the interference per se, either by excess of lipids or by paraproteins. So two conditions that I'm writing here. Point number 2 here would be multiple myeloma, which you can remember by the mnemonic CRAB. Remember, hypercalcemia, renal failure, anemia, and bony lytic lesions present, and then you need to do a bone marrow biopsy in the patient for diagnosis. And then would be hyperlipidemia. These are two important reasons why the person would be having a isotonic hyponatremia. So I can say for this particular part of the discussion that this would be more of a, I would say, a instrument related issue, that the, or I would say procedural related issue. In fact, I should not blame instrument for it. Procedural related issue, that lipids and paraproteins can interfere with the techniques used for measurement of sodium, but otherwise the sodium values in the person would be normal per se. So mainly from the exam perspective, it is the hypo and the hypertonic varieties which are to be remembered, and especially for the hypotonic variety, it is the euvolemic hyponatremia which has to be given importance. And now we are going to talk about what are we going to do if a person reaches that critical threshold of 125 or lesser and then ends up with development of seizures. One possibility is this person suffered from diarrhea, cholera, and ORS was not available at primary health center, or the parents did not give it, or IV fluids were not available at district hospital. So it took a time for the child to be brought to your medical college, and as a result of this dehydration and sodium depletion, the child has suffered from seizures. If he talks about acute hyponatremia, the main concern and the main focus now has to be, is the case presentation given to you that of a case of acute hyponatremia or chronic hyponatremia, because the approach in both of them for the treatment would vary. When it comes to person suffering from acute hyponatremia, the cutoff for acute would be that the event has occurred in the previous 48 hours. You know, suppose I'm describing a case of known case of lung cancer, has not been feeling well for last 1 week, and has been having a fever and a headache and a disorientation. He could not recognize his family members also for past 1 day. And today through a seizure, if it's a long-standing history like the one that I described for a lung cancer case, it would be a chronic hyponatremia. The approach would be different for treatment. But a diarrhea chap ended up with acute hyponatremia, the approach would be different. And there is presence of seizures in this patient. So he'll ask you, what will you do? Your answer would be that we'll start this person on hypertonic saline. Instead of starting normal saline, we'll be starting this person on hypertonic saline, because we could be giving much more larger amount of sodium to this patient so that I can bring up the sodium values. Like suppose the sodium values in this patient is 120. If I increase it to, let me say, 126, the seizures would reduce. He says an increase of as little as, he says that with 3% saline, you need to achieve a hike of only 4 to 5 millicoulomps, and the seizures in the patient will stop. So hypertonic saline, I mean, they'll not ask you the dose, etc. That I'm just trying to tell you that this 100 ml of 3% saline would be given to the person over a span of 10 to 15 minutes. And then we will be rechecking the sodium values again. And most of the time, what's going to happen is that the sodium values will rise from 120, 122, 125, 126 or something like that. And therefore, the seizures in the patient will stop. In case of the fact I said you recheck the sodium values, if in spite of giving a single bolus, if there is no improvement, he says you can repeat the bolus as well. And most of the time with a single bolus, the values tend to rise by about 1 to 2 millicoulomps at least. Let me say patient came at value 124, is having a seizure, then one bolus will be sufficient. It will increase up to 126. Person would be out of doldrums, or I would say out of a life-threatening situation. Suppose he came at 122, I might have to give 2 bolus to the patient. What I'm saying next is only to make you more comfortable with this discussion. He's not going to ask you this, that one bolus will cause, one bolus of 100 ml of 3% saline is going to contribute to how much rise. That's just why understanding purposes, that one bolus usually we find is it causes about 1 to 2 milliequivalent rise. So that's why I said, like, somebody had a seizure at 124, and then, I mean, don't be under that fixation that okay, only at 125 would you be having a seizure. I mean, you will see patients who come to you at 120 and they may not have had a seizure, and then once they downgrade to 115 they might have a seizure. Our neurons, they have a lot of, I would say, plasticity. The neurons have a lot of capability to adjust to these fluid values, but once the critical threshold is obtained, then the person starts having development of seizures. So I'm not saying that this cutoff value is gonna be valid for 100% of the cases. Yes, I would say more than 90% of cases, sodium value is less than 125, you can have a development of seizures, but in some cases it might be 120, some cases might be 115. Like some people who eat less salt, they might be having a better threshold or a lower threshold. I mean, you and me eat normal amount of salt, so the threshold for you and me is 125. But people who tend to eat less salt, restricted salt in their diet, maybe because they're hypertensive, and some people don't like the taste of salt, as you would have seen. Some people, I mean, if they come to our house and they're eating, they say, you eat so much of salt, right? So what I'm trying to say is that the critical values for development of seizure is for majority of population that I've described here, and most of the time with a single or maybe 2 boluses or max 3 boluses, he says that you in a span of about 30 minutes to 1 hour would be able to get good control over the situation, that at least he's not going to end up with status epilepticus and then end up with rhabdomyolysis. There would not be a deterioration of the patient when it comes to acute hyponatremia. We're now going to compare this with what are you going to do in a patient of chronic hyponatremia, where two important situations can be given. I hope you remember either AIDS positive patient with cerebral toxoplasmosis, or it could be lung cancer patient who's been suffering for previous 7 days. And now we are going to discuss some mathematical formulas for chronic hyponatremia. The first and the foremost difference with respect to chronic hyponatremia would be that you need to achieve is a gradual rise of the sodium. In fact, what I'm going to tell you next is itself a question, that suppose a doctor does a fast rise in this case, what's going to happen? Then the term would be well read by you. Fast rise of sodium in a case of chronic hyponatremia can cause central pontine myelinosis. In fact, this central pontine myelinosis word has now been replaced. So let's look at what's the current term. The message is fast correction. That's the complete statement to be remembered by you. Lots of time, even this might be asked in questions. Fast correction of chronic hyponatremia results in, your answer would be answered as osmotic demyelination syndrome. Why the term central pontine myelinosis was replaced was because what they found was that the demyelination is not restricted only to the pons but occurs even outside of the pons, which is why he says currently the more appropriate term is osmotic demyelination syndrome. The clinical presentations of osmotic demyelination syndromes will begin most of the time 2 to 3 days after this fast correction was done. So it's not going to be an instantaneous profile. It will take a while for the manifestations to appear. Now let's look at what will be the manifestations, and they're going to be so gross and so horrendous to listen to that, I mean, obviously the family members would be very unforgiving to the doctor who's done this. The person will be having demyelination with respect to the descending tracts in the brain. So corticospinal pathway will be affected. The person will start developing quadriplegia. Along with this, because the brain stem is also having a demyelination, the cranial nerves coming out of the brain stem are also getting affected. So let me say if the vagus is affected, then this arthria manifestation, I mean the brain stem would be having this important cranial nerves coming out, which would be responsible for speaking with respect to the control of the tongue, with respect to the swallowing activity. So the person will start having brainstem stroke. The message is osmotic demyelination syndrome presents with features of brainstem stroke. And finally, these patients will start developing altered mental status. So I'm going to describe the whole case to you now. I had a patient of lung cancer who was not feeling well, maybe headache, maybe disorientation, and then he had an episode of seizure. Now the doctor who was trying to control his chronic hyponatremia tried to do what we do in acute hyponatremia. In acute hyponatremia, the rise can be done as fast as the fall that occurred. You see, a diarrhea patient, he was okay just before the episode of diarrhea, let's say 135. And once there was an episode that was occurring in this person, there was a value falling down suddenly down to 120. So I upgraded from 120 to, let me say, 125 in a matter of 1 hour or so, and the person is going to be fine. So in acute hyponatremia, you can upgrade faster. But in chronic hyponatremia, you should not upgrade faster, otherwise this osmotic demyelination will occur, and that leads us to the question that what should be the rise in the next 24 hours. The word is not over 30 minutes or 1 hour. Like I was saying, in acute hyponatremia, you can control seizures within 30 minutes to 1 hour. Patient is going to be fine because one bolus will be going over 10 minutes only. Suppose you have to give maximum 3 boluses, which is the usual case, in 30 minutes, and your sodium values have come back to normal. But in this case, I'm not going to do this activity in 30 minutes. He says, do not exceed more than 8 milliequivalents. That's the value to be remembered. In some books, it is written 4 to 6. I mentioned the max upper limit allowed. He says, do not exceed 8 milliequivalents per liter rise. Otherwise, osmotic demyelination syndrome will occur in a patient. And now we'll come to this formula, which is used for giving correction in patients of chronic hyponatremia. In acute hyponatremia, your answer is 3% saline to be given, which would be given, dose would not be asked, but you'll just say 3% saline and administered over. Your answer would be 10 to 15 minutes. And most of the time, a single bolus to 3 boluses are sufficient. In chronic hyponatremia, the 24-hour correction would be calculated by total body water, which would be multiplied by the desired value. The desired value will always be 8 points higher maximum as compared to whatever values given to you. Like chronic hyponatremia patient came at 120. So I'll try to upgrade from 120 to 128. Suppose patient came at 110. From 110, I would like to upgrade to 118 in 24-hour period. That's the key word. I am going to upgrade slowly in this particular case. So whatever is the initial value given to you in the question, it could be 120, it could be 110, whatever be the initial value, what will be the desired value, it will always be 8 points relatively higher than as compared to what the initial value in the patient would be. If he says what will be the total correction for the person, if he says what is the desired value for total correction, then obviously the desired value is 140. I'm taking an average, no, 135 to 145. So average is 140. So I can correct up to 140 over 2 to 3 days. Suppose I raise from patient came at 120, I upgrade from 120 to 128, 128 to 136, and then I can allow patient oral intake goes up to maybe something like 140. So over 2 to 3 days, if I'm trying to stabilize a chronic hyponatremia patient, good. If I try to stabilize them faster, at a rate of, let me say, from 120 to 135, right, in a single day, I would have is a disaster developing subsequently, which is osmotic demyelination syndrome. And next, I'm going to describe a question that has been asked on correction of chronic hyponatremia in the previous years. So let's focus on the question now. The question went like this. He said a 60-year-old female patient has been sick for past 1 week and was admitted with seizures. I've generalized this question because the question has been asked 2 times. One was with like a diagnosed case of lung cancer. Another time he described the AIDS positive patient with seizures, and he had himself mentioned the word cerebral toxoplasmosis, and the person has not been doing good for past 1 week with CNS features like headache, disorientation, and now presented with seizures with a sodium value of 120. Potassium is 4, that's pretty normal. Chloride is 90, that's slightly lesser. Normal range is 96 to 106. And he said calculate the correction to be done in this patient in next 24 hours. If he says this word, calculate the correction to be done for the patient in the next 24 hours, then in next 24 hours, what I'll do is, suppose the admission value is 120, I'll upgrade to 128. But suppose if I modified this question, let us assume in this question, this next 24 hours word is not given. Keep your eyes on the board, guys. Listen to what I'm saying. If he says calculate the correction to be done in this patient and this next 24 hours is not given, then the mathematical value that you will answer here for the correction will be 140, because after all, I want to upgrade from 120 to average value of between 135 to 145, which means the fact that in this particular case, the answer will vary. Now, when it comes to a female patient, you also need to remember that how do you calculate the total body water? For the total body water, I'm going back to my previous slide and telling you that for a male patient, what you need to do is multiply the weight of this male patient by 0.6. If it is going to be a female patient, then you will be multiplying the weight of the patient by 0.5. How to remember it? Females are more fat in the body and men would be having rather more water in their body. So because the question was for a female patient, which is why the multiplication factor I have kept as 0.5. So you need to multiply 60 by 0.5. And guys, most of the time these mathematical questions are either a one-step multiplication or a one-step division. If you're doing some high-fi mathematics, that question is definitely going to go wrong. Here what's happening is you're going to multiply 60 by 0.5, and if he says what is the total, the words are what is the total correction to be given to this patient, then it would be the target value, the desired value will be 140. As a result of it, if I multiply this will turn out to be 600 milliequivalents. The actual question in the exam was calculate the correction to be done in these patients in the next 24 hours. So all you need to do is 60 into 0.5, that would be 30, and then you need to multiply this by 8. This will work out to 240 milliequivalents, which makes the answer to the way the question is framed. For this particular question in the slide, the answer would be 240 milliequivalents. And in case you missed that data, I mean, if the next 24 hours is not given, or if you forget to read this, I mean, one way of reading this question is calculate the total correction to be done. And if you forget that to read that 24-hour data, then you might actually keep the desired value as 140. And therefore the answer will change on to option number D, which did happen with a couple of people. Next up, we're going to talk about hypernatremia, and the first thing on the agenda would be that the sodium value should be more than how much to contribute to dangerously high levels and development of seizures in a person. Then the range would be 158 to 160 milliequivalents. I've given a lower threshold here, 158 milliequivalents per liter and higher, you could have development of seizures. Then the question arises, what would be the causes for development of hypernatremia? And I'll give you a short description. My patient suffered from stroke. He came within the window period of 4.5 hours. So we have done thrombolysis and we got a good result. And now this patient's middle cerebral artery, where there was a big thrombus present, has basically been destroyed and the person is on the path of recovery. You know that in stroke, recovery will not be instantaneous. Though we have destroyed the clot, the person will require an intense amount of physiotherapy to get back on his feet once again. So if a person is having a hemiplegia, we don't expect a stroke patient, the moment we send him back home, he's going to start walking again. He'll require a walker to walk, and that would require a lot of support on the part of the family. And the family members would also have to go out and go about their earning part also. Like this old man who has recovered from stroke in our hospital, he has been discharged home and now he lives with his son and daughter-in-law, and both have to go to work because they have to work in an office. So if this old man is alone in his house and it's a hot Indian summer and they don't have air conditioning, and if he's thirsty and he can't get up from the bed by himself and go to the refrigerator or go to the kitchen and get water by himself, then due to physical disability in old age, if you don't drink water, it's going to cause increase in the sodium concentration in the body. Sodium concentration would mean sodium divided by water in the body. If you don't drink water, the denominator in sodium concentration, numerator is the sodium, denominator is the water. If the water is lesser, the sodium values will rise. So for physical disability, I mean, it may not only always be a case of stroke. He might describe a case of a lady who's underwent a bilateral total knee replacement. Now, after a bilateral TKR, we don't expect the person to start walking from the same day, and the person was discharged home. And it will require a lot of physiotherapy for this particular lady to get back on her legs once again. She'll have to walk with a walker. And again, same situation, nuclear family, the grandchildren have gone to school, the husband and wife have gone to their office, and the old lady is alone back in the house and she's thirsty. Yeah, she may not be able to get up and go to the kitchen and get herself a bottle of water. So neurological illnesses like Alzheimer's disease or stroke, or person who's undergone important surgeries like a total knee replacement, total hip replacement, the physical disability is overall the most common cause for development of hypernatremia in a patient. Just like in hyponatremia, it would be fluid loss due to diarrhea, vomiting. The next cause to be remembered would be from endocrine system, though diabetes insipidus and SIADH are covered even separately in the second video. Just after this video, you'll come across a video by the name of Bartter syndrome, Gentleman syndrome. There I've talked about SIADH and Schwartz criteria for SIADH and diabetes insipidus as well. But at the moment, I just want to say that if a person is having central variety of diabetes insipidus or nephrogenic diabetes insipidus, because there's going to be loss of water from the body, therefore again the sodium concentration in the body will begin to rise. Patients of diabetes insipidus would be having polyuria. Due to polyuria, I can say they'll be having dilute urine. And because of dilute urine, most of the time in diabetes insipidus, you'll find that the urine osmolality of the patient would be less than 250 milliosmoles. Let's take up another case. This time I'm describing a patient of pontine stroke. Though there can be environmental reasons for excessive sweating also, like this is an athlete who's playing a football match at a very hot place. So he's going to be sweating profusely, and loss of water from the body can cause the sodium concentration to rise. Or I mean, instead of talking about an athlete suffering from an environmental aspect, or let me say a construction worker in Dubai, in a hot summer of Dubai at 50 degree, he's making a building. So in that extreme hot environment, because he's going to be sweating, he's losing water from the body, and therefore sodium concentration will rise because water is becoming lesser. Instead of talking about environmental issues, in the exam he can talk about pontine stroke and excessive sweating. Then the next patient of mine is on lactulose, and lactulose causes osmotic diarrhea. If lactulose is given in excess, you see, excess of anything is bad. I mean, lactulose can be used in hepatic encephalopathy also. Lactulose is used even in patients of constipation. So what I can say is that lactulose can contribute to osmotic diarrhea. Once this osmotic diarrhea will show its effect, water loss from the body will again contribute to increase in sodium concentration, or even mannitol excess, I can say. When I say that, the query in most people is, sir, you said mannitol for hyponatremia. See, when mannitol is given regularly in patients of raised ICP, it's going to cause a diuresis, agreed, and that can contribute to, I mean, if you when you are infusing mannitol, and at that time if you draw a sample, because mannitol will be in the blood at that time, so the plasma osmolality will increase, and you will have is a hypertonic, because it will draw water also along with it. So solvent drag will come up, and mannitol infusion results in development of hypertonic hyponatremia when it is being infused. But if I am giving excess of mannitol, once it gets filtered into the kidney, then it will cause osmotic diuresis in excess. I said two things. One is, I'll just go back in my slide. What I'm telling you is that if a person is being given mannitol, during the infusion part, if you take a blood sample, because mannitol will be in the blood, the plasma osmolality will be increased. But after all, it will get filtered into the kidney and will cause diuresis, and that's its job. If you use too much of mannitol, if you use mannitol excess, that's what he says in the book. Like I was saying, lactulose excess causes osmotic diarrhea. Mannitol excess will cause excess of osmotic diuresis, and because the free water clearance would be increased, as a result of it, the person will suffer from hypernatremia. Now, he will ask you what are the fluids which are to be used for correction in a person of hypernatremia. There can be two situations this can be asked. One can be that you had just finished your shift, you were going back home, and your nurse just showed you a report. She was entering this report in the computer system of the hospital, or she was putting it in the file like we do in government hospitals, the written report. And she just asked you, sir, I've entered this report. Sodium is 150. Normal is 135 to 155. This is an admitted patient, is asymptomatic. He might be admitted for any reason. But at the moment, this post-surgery patient is having on day 2 of surgery a sodium value 150, and the nurse is asking you, sir, what should I do for this person? Because at 150 she's learned, once they go up to 160, 150, at seizures can occur. So she asked you casually, doctor, I mean, something is to be done, any advice? So if a person can take orally, most of the time post-operative patients, day 2, day 3, we allow oral intake in post-surgical patients. So I will tell the nurse to allow liberal amount of water intake in the body, because if you take a lot of water, then this water will cause dilution, and the sodium values will start decreasing from 150 down to gradually 145 and lower. So if he says asymptomatic hypernatremia, then liberal water intake is all that is required. But if the person is symptomatic, if he starts having seizures, as I've explained to you, then you need to give fluids to the patient. One question that I can put up before you right here, and I would not like you to look at your notes at the moment, just tell me, like I taught you, fluid of choice for hyponatremic seizures would be 3% saline. What fluid would you be giving to a person with symptomatic hypernatremia? I gave a pause a few seconds because I wanted you to think. Your answer would be 5% dextrose. Yes, guys, when we were discussing raise ICP, I was telling you hypotonic fluids are contraindicated in patients of stroke. Hypotonic fluids are contraindicated raise ICP because they worsen cerebral edema. But the same fluid which I was telling you as contraindicated in head injury patient, contraindicated in a raise ICP patient, hypotonic fluids are not given in stroke. They're not given in a road traffic accident. In road traffic accident, you need to give hypertonic. It will remove water from the brain, reduce the swelling in the brain, lower the pressure in the brain. That fluid which was told to you as contraindicated in raise ICP is now the answer of choice or the fluid of choice. I repeat once again, I'll write both the questions here. One in the exam they said which fluid is contraindicated in a person with raise ICP always. Your answer is 5% dextrose. Why? Because it's a hypotonic fluid. But now I need hypotonic fluid to be administered to the patient so that I can downgrade the sodium from 160, 155, 150, 145, and therefore 5% dextrose would be used, or you might just use the word half normal saline as well. Once you get this right, then he will ask you how much fluid would be required in the patient. So we again have a formula as compared to the hyponatremia formula. We'll just practice this hyponatremia formula once again. All you need to do is multiply the total body water of the patient by the desired value minus the actual value. For the hyponatremia component, I've told you for a 24-hour correction, don't go beyond 8 milliequivalents in a 24-hour period. This is per day. This is per day. This is the total correction of the patient. That is 600 milliequivalents. That would be over 48 hours and even going up to 72 hours. I want to be as low as possible in chronic hyponatremia. In acute hyponatremia, I can cause it to rise back to normal as fast as it has fallen. Now, coming back to the hypernatremia component, the formula to be remembered would be total body water. Once again, total body water formula I've explained to you. Weight multiplied by, in males, 0.6. In females, it's going to be 0.5. And then you need to get this. I mean, as far as what I say next, most guys have a bit of problem remembering it, but then it's not a problem. Whatever is the actual value given in the question, like actual value is 160, so you'll put a 160 minus 140. And the whole thing is to be divided by 140 as well, and you would have answer for how much fluid is to be given. And let's just take an example like this. He describes a case of 60-year-old female, and then he describes she underwent a hip replacement surgery, and she has been admitted with headache, disorientation, and development of seizures. The doctor noticed that the sodium value of this lady on admission is 160 milliequivalent. She's undergone a THR or a TKR in your hospital previously, or is a known case of diabetes insipidus. Now he says what would be the correction that would be required for this patient. So for a female patient, it is 60 into 0.5. The actual value given in the question is 160. We just need to do a bit of mathematics here, which I've already done so that I can save some time. And the value that you will turn out for the total fluids for this person would be 4.2 liters of fluid to be administered. This fluid would not be administered over 24 hours. Again, I would like to span it out because just like I was telling you that we should not be doing a fast correction of hyponatremia, we should not be doing a fast correction of hypernatremia also. Hypernatremia again can be acute or chronic. Majority of cases it's a chronic presentation. Majority of cases like physical disability or I can say diabetes insipidus, it's gonna be most of the time a chronic presentation. So we should try to bring it back to normal again over a span of 24 to 48 hours rather than trying to ensure a sudden decrease of values towards normal. The logic behind this is again because sodium is an important determinant of plasma osmolality. So if you're gonna cause sudden changes, the words are sudden changes in plasma osmolality, it's always gonna be counterproductive for the patient. I mean, it would be harmful for the brain. The fluid shifts across the brain. So a gradual rise is recommended, except for the scenario of acute hyponatremia. Next up is going to be aspects related to potassium. Normal potassium values are between 3.5 to 5.5 milliequivalents per liter. Values less than 1.5, though there's a range around 1.5 to 2.5, but anytime the potassium values decrease to less than 1.5 milliequivalents per liter, then the person can die. And I would not like you to look at the printed notes at the moment. Just tell me what is the leading cause of death in a person with hypokalemia. Like in hyponatremia or hypernatremia, I was saying person is having seizures, and therefore the person could be ending up with the recurrent episodes of seizures, and that could result in death due to lactic acidosis, or it could be hyperthermia that could kill a person. Similarly, potassium, if it reduces less than 1.5, why would the person die? Your answer would be muscle paralysis, and one of the important muscles that we're talking about at the moment is the main muscle of inspiration, diaphragm. So diaphragmatic paralysis contributes to mortality in hypokalemia, and vice versa. Let me say if the values go more than 8 milliequivalents per liter, the clinical situation can be acute kidney injury, acute tubular necrosis. Once kidney is responsible for excretion of potassium, and if the potassium values will rise, the person would again die or can die, and that would be due to diastolic arrest of the heart. He may not write diastolic arrest, he might just say cardiac arrest, but the point is potassium is important for cardiac conduction. Every time potassium rises, the gradient between the inside and the outside of the myocardial cell changes, and that affects the resting membrane potential and can result in diastolic arrest in the person. Another aspect that I would like you to remember is that every time a child is having diabetic ketoacidosis, because there's going to be insulinopenia. Therefore, sugar cannot go in the muscles. If sugar cannot go in the muscles need energy, right? So there's going to be burning of fat, which will generate ketones, and therefore the pH of the patient will begin to fall. Because in diabetic ketoacidosis, there is a insulinopenia. Therefore, the sugar values will begin to rise, and this sugar will exhibit a solvent drag, and this solvent drag would then contribute to potassium efflux, which explains the fact that why in a patient with diabetic ketoacidosis do you read about hyperkalemia at the time of presentation. When you will treat this patient with insulin drip, then insulin drip will do opposite. It will send potassium to go inside the cells. But at presentation, the values of potassium would be increased. And therefore, you can remember it like this, that the pH of blood always shows an inverse relation with potassium. That is, and this is a universal rule to be remembered by you, which is whenever you have acidosis, pH is decreasing, potassium will rise. Vice versa, if I say metabolic alkalosis, there would be a potassium value decreasing, hypokalemia. So remember both the facts. With acidosis, hyperkalemia, inverse relation will satisfy it. If I say alkalosis, pH is going to fall. And now I'm going to tell you another reason why do you have hyperkalemia with states of acidosis. So let me say if a person is having, at the moment I'm not specifying the condition. I'm just saying if hyperkalemia is present, how will it affect the kidney? The main function of the kidney is maintenance of electroneutrality. If potassium in the blood will be more, it will come in the urine also. So I can say person is having kaliuria, is having positive charges in the urine. Because there will be more positive charges in the urine, therefore the kidney will try to reduce the excretion of hydrogen ions, because hydrogen ions are also positive charges. I repeat that again. I said kidney ka basic function is electroneutrality. It will try to control. If there are more positive charges coming in the urine, it will reduce the positive charges, that is hydrogen ions will not be excreted. So let me just write it. What the textbook says is that whenever potassium gets elevated, it results in inhibition of tubular excretion of hydrogen ions. You see, hydrogen ions is excreted in our body as NH4+, because it's ammonia along with hydrogen ions, and the reason for this is electroneutrality. More positive charges, the kidney is trying to reduce the number of electrical charges in the positive charges in the urine, and therefore there's a brakes being applied for the release of hydrogen ions. And because you are not having a release of hydrogen ions in the body, there's gonna be a hydrogen ion accumulation, and that will explain why do you read about acidosis being associated with hyperkalemia. You see, earlier the logic that I was telling you was valid for diabetic ketoacidosis, that pH is having an inverse relation with potassium due to the aspects of solvent drag, but then not all the cases that come to you would be having diabetes only. No? So suppose somebody is not having acidosis, and still, the point of mine is that he's having hyperkalemia. Then how is hyperkalemia contributing to development of acidosis is what I've explained, that there would be inhibition of tubular excretion of H+, and therefore high H+ ion accumulation triggers acidosis in the person. And therefore there's a mathematical rule also, though the rule is not important, it's the physiology point. The 3 points that I've highlighted on the slide are important. The mathematical rule is that if potassium in the blood rise by 0.7 milliequivalents, like suppose potassium is 5, it rises from 5 to 5.7, then a rise of potassium by 0.7 milliequivalents, the pH of the patient will fall. and this fall would be by approximately 0.1. So that's a mathematical aspect, 0.7 and 0.1. Again, the inverse relation has to be remembered, that pH and potassium have in both the aspects that are high, whether it's ketoacidosis, whether it's going to be hyperkalemia due to any other reason. The bottom line is you're going to have an inverse relation. So in this slide, there were a couple of general issues with respect to potassium that I wanted to highlight, and now we'll focus on the aspect of hypokalemia. We'll talk about what are the causes for it, how would you manage the patient, what are the interventions to be done in a person. And I've already sensitized you to the fact that hypokalemia can be lethal enough. I mean, initially patient will have muscle cramps, weakness, paralytic ileus, bowel sounds will disappear, but then subsequently there could be a diaphragmatic paralysis which can result in expiry of the patient if ventilator support and potassium supplementation, which is IV correction, is not done. The question that came in the exam said which electrolyte imbalance can trigger. In fact, I'll put it different way, because here if I say the name of arrhythmia, it will become easier for you. So I'm putting a question here before you, and I don't want you to look at printed notes. Which electrolyte imbalance, I mean electrolyte imbalance is hypokalemia. Which arrhythmia is seen with hypokalemia? With hyperkalemia, we have bradycardia, we have sine wave pattern, then there's a conduction block, and finally there's a diastolic arrest. If potassium decreases, we again have arrhythmias developing in a person, and your answer would be given as torsatus de pointes / polymorphic ventricular tachycardia. Point number 2 is important because lots of time they love to ask about arrhythmias in the exam, and for polymorphic VT / torsatus de pointes, I would like to mention two etiologies here separately. Both when I'll be describing hypomagnesemia before you in the later part of this video, and currently I'm talking about hypokalemia. Both of these are associated with development of polymorphic VT, where the diagnostic feature of polymorphic VT has been discussed even in the cardiology section, prolonged QTC. There would be a small subscript C written here, that would mean a corrected QTC, and the formula here is QT divided by the root of RR interval. I mean, the formula part you can still neglect, but then you need to remember two aspects. Causes of polymorphic VT are hypo-K and hypomagnesemia. Diagnostic criteria is increased in QTC. And once we get the causes of death right, then we need to obviously elaborate why would hypokalemia be occurring in a patient. So let's look at the first important reason, which would be dietary, that the intake of potassium in the person is lesser. And if intake is not a cause, then the next cause to be remembered by you from the exam perspective is metabolic alkalosis. I've already told you that the pH and potassium have an inverse relation, which is why you can work it out. The third reason for this would be that any condition whenever there is an excess of sympathomimetic stimulation. Even sympathomimetic stimulation results in potassium to go inside the cells. Sympathomimetic stimulation results in potassium influx. Like traditionally we read insulin drip contributes to potassium to go inside the cells, but sympathomimetic stimulation, catecholamine in excess, also contribute to potassium influx in a patient. And to give credibility to this, I'll say first a general statement, then I'll write down 2 points. So listen to the general aspect. You would have read that whenever a person is having hyperkalemia, we tend to give salbutamol nebulization. It looks very surprising because salbutamol nebulization is used for treatment of acute exacerbation of bronchial asthma. It's a bronchodilator. What is salbutamol doing in hyperkalemia treatment? See, when you use salbutamol for management of hyperkalemia, the dose used is almost 4 times more than what you use in asthma. The reason why you're giving so much of salbutamol to the patient is because it is causing excessive sympathomimetic stimulation. One of the side effects of salbutamol is sympathomimetic stimulation in excess. Person can end up with tremors. There would be tachycardia. Why am I deliberately causing a sympathomimetic stimulation in the patient? Is because it has been documented that it causes potassium to go inside the cells. So for treatment of hyperkalemia, the word is treatment of hyperkalemia, excessive sympathomimetic stimulation using salbutamol helps in sending potassium inside the cells. That's the benefit part, right? I mean, we use salbutamol for management of hyperkalemia because it sends potassium inside the cells. And once I've explained that to you, I just want to say that lots of time in trauma cases, we might be having hypokalemia because there could be a lot of pain associated with trauma. Excessive sympathomimetic stimulation can result in potassium to go inside the cells. Another example that I want you to remember is thyrotoxic periodic paralysis. You see, when you go to the neurology section, I've talked about channelopathies like hypokalemic periodic paralysis, hyperkalemic periodic paralysis, which are calcium channel defects. But at the moment, I'm talking about thyrotoxic periodic paralysis. What he says here is that, let me say it's a lady with Graves' disease. She's having excess of T4, T3 in the body, and T4, T3, they again have a sympathomimetic drive. So once it drives this if the sympathomimetic drive increases, there's going to be potassium going inside the cells, and therefore even with TPP, thyrotoxic periodic paralysis, we document hypokalemia to be present. Point number 4 will be relatively the easiest one out of all of these. At least one is a bit straightforward. 2 and 3 take a bit of time to comprehend and understand, as I've tried to invest time here. And for the fourth cause of developed hypokalemia, I personally feel this would be the easiest one for anybody to understand, that kidney helps in regulation of potassium, and in case there's a renal wasting happening, then you would be having hypokalemia. The hormone that helps in controlling the potassium values is aldosterone. I can just draw a diagram, a crude diagram like this, that aldosterone causes gain of salt and water, and at the same time it is also responsible for urinary loss of potassium as well as that of hydrogen. If a person is having excess of aldosterone, then I'll just make these arrows relatively more thicker to say that now there's going to be more salt and more water coming back in the system, but there is also going to be a corresponding increase in the urinary loss of potassium as well as that of hydrogen. So the conditions that I can write here can be like Conn syndrome, or I can write bilateral adrenal hyperplasia. In both of these conditions, you will read person is having hypokalemic alkalosis. Then subsequently, in the video which is just after this electrolyte imbalance, you will find a video on Bartter syndrome, then Gentleman syndrome. These are also conditions which have metabolic alkalosis and simultaneously a hypokalemia component present. So, I'll not get into the technical details of Bartter and Gentleman at this particular juncture, because otherwise it will change the entire focus of discussion. They're already covered, as I said, in the second video, subsequent one after that. So Bartter and Gentleman are renal tubular disorders. In Bartter syndrome, at the moment I can say is defect lies in the thick ascending limb of loop of Henle. In Gentleman, the defect lies in the distal tubule. And in both of these conditions also hyperaldosteronism can occur, and thereby the urinary loss of potassium can explain hypokalemia component in the patient. The fifth cause is again vomiting and diarrhea. So as far as fourth and fifth, that is hyperaldosteronism, per se, I think in vomiting and diarrhea, nobody has a problem in understanding. From the causes perspective, if they're going to ask you this in the exam, most of the time they're going to quiz you regarding this concept which I said pH has an inverse relation with potassium. That will solve point number 2 for you. And the third point to be remembered is excessive sympathomimetic drive also contributes to potassium to go inside the cells. So once you get the causes right, we'll next focus on the way we diagnose these cases, what would be the ECG findings, and what would be the correction given to these patients, and what would be the magnitude of correction given to these patients. The earliest symptom that would be experienced in hypokalemia patients would be muscle cramps. And if you have ever experienced diarrhea ever in your life, then you can understand how bad this can be. Muscle cramps and generalized weakness is the initial reason why these patients come to you. And as the hypokalemia component becomes more severe, let me say mild, I can classify, though there are various classifications. The most accepted one is 3 to 3.5 is mild. Then as we go down towards 1.5, I can say from 1.5 to 3, it would be moderate, and less than 1.5 is either referred as severe or sometimes book refer as life-threatening. So I've not written that classification because there are different ones available across different books. You might get values like 3 to 3.5, then 2 to 3.5, or 2 to 3 would be moderate. So let's not get into the controversy, because ultimately from the patient's perspective, what's going to happen is that the bowel sounds of the patient will decrease, and therefore gross abdominal distension can occur. At this juncture, rather more important than focusing on the ranges or different classifications, the more important thing would be to understand what is the leading cause for development of ileus after post-operative state. The answer is hypokalemia. Subsequently, flaccid paralysis, because neuromuscular transmission will be hampered. So flaccid paralysis will be experienced. This flaccid paralysis will be affecting the diaphragm also. So instead of writing diaphragmatic paralysis, he might just mention, any patient with diaphragmatic paralysis, ventilator support is required. And getting a ventilator in India especially at a peripheral place, would obviously be difficult. So carbon dioxide retention can occur in these patients primarily because of the hypoventilation part that would be occurring. And once this person will start deteriorating, coming to the workup of these patients, I'll be drawing a blood sample and checking out the serum potassium values. But over and above this, what we also need to do is check out TTKG, that is transtubular potassium gradient. If the value turns out to be more than 4, though there's a formula also for TTKG, as the English term indicates transtubular potassium gradient, we'll have to check out the urinary potassium and the blood potassium values, urine volumes as well. Formula would not help you in the exam, but the value that I've told you, TTKG more than 4, indicates renal wasting of potassium. The renal wasting of potassium causes, whenever you read this term, it implies that there is going to be hyperaldosteronism. Conditions for hyperaldosteronism were like Conn's bilateral lateral hyperplasia, the standard ones, or Bartter or Gentleman syndrome, which are again related to different defects, defects in the different parts of the kidney tubules. The third test that I'm going to do in the person is ECG. And ECG findings of hypokalemia have been discussed in cardiology also. So I think it would be a repetition for you. Let's do this quick repetition. The vertical height of the T wave in a normal person in the limb leads would be about 5 mm, in the chest leads would be about 10 millimeter, and T wave amplitude tends to reduce. In hypokalemia, the arrow is going down. So what we also find is that the T wave amplitude tends to become lesser, and then subsequently there is also possibility that T wave might disappear. And another possibility is that the T wave might even become negative. So T wave inversion, I've written a short form as could be written in a MCQ. TWI means T wave inversion could be present in patients having hypokalemia as the potassium values start going from going down to 3, 2.5. That's when the T wave will turn negative as well. When the T wave will go down, then ST will also follow. This part of the ECG, where I put the pointers there, the end of the S and the start of the T, that is the ST segment, will also start going down. So therefore, the ECG in this person will start appearing like the way I'm currently sketching before you. Though this kind of a sketch might even be encountered in patients who are having a non-ST elevation MI. One of the differential diagnoses of T wave inversion can be unstable angina, non-ST elevation MI, and even hypokalemia. So I've shown a ST depression with the T wave inversion. The next aspect which has been asked in the exam is that the amplitude of the P wave in these patients will start increasing. You can remember like this: the last wave of the ECG will become smaller, will become negative, and the first wave of the ECG will start becoming taller. So the word is pseudo P pulmonale. Traditionally, we read about P pulmonale with pulmonary artery hypertension, but here there's no pulmonary artery hypertension. So meaning of the word pseudo P pulmonale is that the P wave amplitude is more than 2.5 millimeter. In absence of pulmonary artery hypertension, the traditional definition of P pulmonale is P wave vertical amplitude more than 2.5. Here there is no pulmonary artery hypertension, still the height is more due to the electrolyte imbalance. That is why we're gonna call it a pseudo P pulmonale. Another finding which is very important and is asked in the exam is prominent U waves. And when you read it, I would like you to remember, and I would like to remind you, in fact, that if it just says U waves are found in, your answer is U waves are found in ECG of a normal person also. You see, U waves are found in ECG of a normal person due to delayed repolarization. But if you read the word prominent U waves, then it's going to be hypokalemia, which is to be taken into consideration. And along with this, the cardiac conduction will be hampered, the conduction will become slower. So PR interval will also be increased. So there are 5 ECG findings that would be present in this patient. You need to remember each one of these. The minimum that I expect you to remember at this juncture is at least the word prominent U waves. Why that is so is because sometimes in questions he might say QU prolongation, and I do recall one of my students once, he messaged me, he says, sir, did you write, was there some typographical error in your writing? I read QT interval, you written QU. So my point is, because in hypokalemia T will disappear, T will become smaller, disappear. So after that you are seeing U only. So as a doctor, what you're gonna see is not a QT which will be prolonged, but it will be a prolonged QU interval as well. These are a couple of ECG findings, though ECG is not very sensitive. I'm saying it's not very sensitive to the electrolyte imbalance, that is potassium fluctuations. But yeah, it helps you give credibility to the fact that you are dealing with a genuine hypokalemia in a patient. And once we have done this, now we need to see what should be done. Now, for the management of a patient of hypokalemia, the point to be remembered is that if he gives you a scenario of mild hypokalemia and the potassium values are between 3 to 3.5 milliculents per liter, then what would you be doing in this case? Your answer would be not a intravenous correction. You'll be going ahead with the oral correction. There's a medicine, the brand name I'm saying at the moment, that is pot chlor. So you can give this pot chlor diluted with water. You should not give it undiluted because it can cause damage to the GI mucosa. So it should always be diluted with water when administered to the person, and the potassium values will gradually start coming back to normal. The clinical situation I can give is a patient was admitted in a hospital with acute congestive heart failure. In any patient with acute pulmonary edema, acute congestive heart failure, we tend to use Lasix. You had started this guy on Lasix 40 milligram. You had to give high dosages of Lasix. Then multiple, by plus I mean multiple dosages of Lasix were given to this patient over the previous 2 days, which has resulted in saving the life of this patient because it will resolve the pulmonary edema. Remaining treatment was also given. Lasix, morphine, nitrates, oxygen positioning of the patient was done. But because Lasix is going to cause a kaliuria, therefore hypokalemia can set up. Now the same patient of congestive heart failure, after 2 to 3 days, he has recovered. Now you have started oral intake in this person also. So because your patient is on the way to recovery, but you found that he's complaining of muscle cramps and weakness because of this high dosages of Lasix that were administered to this patient in the acute first 2 days of admission with acute congestive heart failure, then because he's fitting into this mild hypokalemia, you need to give oral correction with pot chlor and the person will do fine. But if the values in the question are less than 3 milliculents, that's where problems start occurring because the bowel motility is hampered, and even if you give it, because the motility part is hampered, the risk of aspiration can increase. So in those circumstances, he says that you must try and give a intravenous correction to the patient. Lower the value, you have to give less than 3. Anytime it's the IV correction. And once you give this correction, like suppose patient is admitted with a value of 2 milliculents, so from 2 to 3 you will correct it by IV correction. But once the values will reach about the values of 3.1, like the next day you came for the round and you found now it is back to 3 from 2.0, it's up to 3.1, then your decision will be, okay, we'll discontinue IV correction, because side effect of IV correction can also be phlebitis. It can cause, potassium can cause a substantial amount of thrombophlebitis. So once I've upgraded from, let me say, 2 to 3 milliculents, then I'll stop the IV correction in the patient, and to increase from 3 to 3.5, assuming that by 3 the intestinal motility would be back to normal, I will then start oral pot chlor in the patient. So for this deficit, I'll discuss a question before you where he described a patient is an amphotericin B. Maybe it could be a case of cryptococcal meningitis. A AIDS positive patient who's on amphotericin B is now having weakness and cramps. The doctor did a potassium and it turned out to be 2.3 milliculents, and he says calculate the IV correction which is to be done in this patient. Well, first I'll tell you a basic rule that if you want the potassium in the blood to increase by 1 milliculant per liter, this is rise in the blood of the person, then how much potassium chloride should you give to the patient? Then the mathematical rule is to cause a 1 milliculant rise in the blood, 200 milliculents of potassium chloride should be administered to the patient in the form of a drip. That is, this 200 milliculents will be added to the IV fluids, the 24-hour IV fluids of the patient, and then would be given in the form of an infusion. We never give a bolus shot of potassium because it can result in diastolic arrest. So KCl should always be given diluted. Now, in my case, the actual value of the patient is 2.3. I will upgrade from 2.3 to 3, possibly by tomorrow morning. And when I come for the round tomorrow morning, because the values would be in the range of 3 or a little higher, then 3 to 3.5, as I've explained to you, because most of the time the patients tend to improve. So wherever possible, he says, wherever possible, you should try and give a oral correction to the patient. So my target in this patient is not to increase from 2.3 to 3.5. 2.3 is the actual value of, that's the presenting value of the patient. I don't want to upgrade from 2.3 to 3.5. I want to upgrade from 2.3 to 3.0. That would be a hike of how much? That would be a hike of 0.5 milliequivalents per liter in the blood, as you can see, mathematics. And then how much KCl should be given? So let's do mathematics here, that preliminary mathematics that we do in 7th and 8th class. For 1 milliequivalent rise, you need 200 milliequivalents. So for 0.7, how much would you require? You just need to multiply this by 200. I'm doing this preliminary mathematics. Doctors are bad at mathematics, so I'll repeat that again. For 1 milliequivalent rise in the blood, if you require 200, then for 0.7 rise, I'll multiply 0.7 by 200, and the mathematical value that I'll arrange or arrive at here would be 140 milliequivalents of potassium chloride that must be administered to the patient. This 140 milliequivalents of potassium chloride, which is now gonna be administered, should be diluted, should be added to the IV fluid, that is normal saline. Here he will ask you which of the following fluid would not be recommended for this patient. Remember, for hypernatremia of the symptomatic variety, I was teaching you 5% dextrose, but 5% dextrose or 10% dextrose, any dextrose solution is not to be given in a person who is being administered potassium chloride. Let's look at why. If you administer dextrose solution to the patient, then sugar in the body will rise, because after all, dextrose is sugar. If sugar will rise, it will trigger endogenous insulin production. And what does insulin does? It causes potassium influx, and that will worsen the condition. Remember, patient came to us with hypokalemia. And if I'm going to give a dextrose based solution to the patient, I'm going to increase the endogenous insulin levels, and this is going to drive potassium inside the cells, and it will worsen the original existing hypokalemia of the patient. If you missed it, I'm going to say this once again, quick 30 seconds into why should you not be giving dextrose based solutions to people who are having a hypokalemia, because dextrose based solutions will cause rise of sugar, rise of insulin, and insulin will drive potassium inside the cells. So the original hypokalemia of the patient will be worsened, and therefore the question was which fluid is not to be given? Answer is dextrose based solutions. Which fluid can be given? Your answer is normal saline to the patient. The basic rules which are to be remembered at the moment is that the fluid in which KCl is to be given to the person is always going to be normal saline. The next aspect that I'll say before you has been asked in FMG exam. The question said which electrolyte imbalance can be coexisting with hypokalemia. This is a fact-based data, and this is more from pediatrics. Lots of time we have children with protein energy malnutrition with persistent diarrhea. So these children are not only deficient in the potassium component, because diarrhea will obviously cause a development hypokalemia, but it also causes urinary loss of magnesium. So hypomagnesemia coexists. The question said which electrolyte imbalance tends to coexist with hypokalemia. The statement to be remembered is hypomagnesemia coexists with hypokalemia, which means that even when you will treat the hypokalemia of the patient, the weakness will still persist, because weakness is a common symptom between both hypokalemia and hypomagnesemia. When I discuss magnesium subsequently, I'll get into the reasons behind why weakness is a symptom of hypomagnesemia. At the moment, the universal statement of mine is a child with PEM grade 3, grade 4, grossly malnourished child with persistent diarrhea was admitted into your hospital, and you're noticing his reflexes are lesser, the tone of the muscles are lesser, the baby is not able to sit up in the bed, there is neck floppiness in the child. You have given KCl correction. Potassium was low, let me say 2.5, let me say 3. You have given the IV correction. You have also given oral correction, but in spite of giving IV and oral correction, if the weakness persists, that's the clinical learning point here, guys. If in spite of giving potassium correction, both intravenous and oral, to a PEM grade 4 child with persistent diarrhea, if the weakness of the child, the neck floppiness of the child persists, then you must suspect which electrolyte imbalance. Your answer is hypomagnesemia. The question was pretty straightforward. Which electrolyte imbalance coexists with hypokalemia? Though I give you a clinical domain before it, which is the usual presentation in our hospitals. The next aspect that is asked is that how much potassium chloride can be given from a peripheral line? What would be the rate per hour? And how much potassium chloride can be given with the help of a central line? Obviously, in emergency, you could be using a central line like a femoral vein or a subclavian vein in a patient. The potassium infusion, why that value that I'm telling you is mainly because of the risk of phlebitis that can come up. I mean, even when you give 10% dextrose, even that causes phlebitis. If you have ever given 10% dextrose or higher concentrated solution like 25% dextrose, person will say, sir, I feel as if my skin is burning. I mean, he'll say, doctor, you pushed acid in my circulation. I mean, he can say, sir, I can feel that the fluid is moving up. So 10% dextrose, 25% dextrose, they cause substantial amount of phlebitis, and so does KCl infusion. So they've limited that when you want to give KCl infusion with the help of a peripheral line, the rate at which you should be giving is in the range of about 10 to 15. Some books mention 10 to 20. What I'm mentioning is a reference from current CMDT 2023. In fact, I should refer the reference here also, because otherwise the query will come up, sir, we have read 20. So I'll tell you when to answer 20. At the moment, he says CMDT 2023, current edition mentions with peripheral line, you should be giving about 10 to 15 milliequivalents per hour. But in case there is a life-threatening situation, potassium is very low, 1.5 or even lesser, and you are forced to give it with help of a central line, then which central line would be preferred? Either you could use femoral or you could use a subclavian vein, whichever is comfortable. And then the value that is to be given is 20 milliequivalents. Here also there's a slight controversy. Some books say subclavian, some say femoral. Personally, if you ask me, though I'm not writing it down, it's femoral vein that should be used, because if you give concentrated potassium in a central line, subclavian, then if this vein will get thrombosed, then you can understand that the distal circulation will be hampered. There would be edema developing in a person. So he says wherever possible, infuse it via the femoral vein. If not, then obviously the standard subclavian access can be done. So the rates would be like this, that is 10 to 15 milliequivalents per hour via peripheral line, and 20 milliequivalents per hour with help of a central line. That's mainly to reduce the risk of development of phlebitis, and central line access is mainly for critically sick patients. What I say next is some general rules with respect to potassium administration. The first one is do not give at a rate more than 20 milliequivalents per hour. Again, everything is a range. So he says that in critically sick patients, you can go up to 20, but do not exceed more than this, again, because of the cardiotoxicity, I can say, or the risk of diastolic arrest in a patient. And obviously you can never ever give it undiluted. The next thing that I'm telling you is again very important and has proved to be very productive in our hospitals to prevent over infusion of potassium. He says that your nurse should be given a standard instruction that how much potassium can be present per liter. Then your answer is 40 milliequivalents. So remember that what I was telling you initially was not in liters. That what I was telling you was how much can you give per hour. But at the same time, I'm also telling you that to prevent overinfusion being given, he says that the concentration should not exceed more than 40 milliequivalents per liter. They've also set this rule that do not give more than 240 milliequivalents on a 24-hour basis. These are three standard rules with respect to potassium infusion, which if respected, then the chances of phlebitis, chances of life-threatening complications, overcorrection can be minimized. Two important reasons wherever every time potassium is asked is, one is diabetic ketoacidosis. The learning point for us is that diabetic ketoacidosis, when the patient presents to us at presentation, because pH and potassium have an inverse relation, so hydrogen ions are going down, the potassium values would be elevated. But once you will start the person on insulin drip, then there would be a redistribution of potassium, and redistribution of potassium will cause hypokalemia to develop in a patient. We are not having potassium being kicked out of the body here. It is just a redistribution that are occurring. Another scenario where you could be having this presentation is hyperosmolar coma. So diabetic ketoacidosis and hyperosmolar coma are one of two common indications where they talk about potassium per se. The last statement is a very general statement. What are the potassium rich foods that you would like to give to patients who are having chronic hypokalemia? Like suppose potassium went up to 3.2, 3.3 and is stubbornly stucking at that level. You don't want it to rise up to 3.5. You don't want it to be stuck at that level. You want it to rise to 3.5 before you discharge the patient. So what you will do is you will advise the patient to take fruit juice. Apart from fruit juice, banana would be rich in potassium. So is coconut water. These are three things that even non-medical people would be doing by themselves once you tell them that potassium in their body is lesser. Apart from this, dry fruits also contain potassium. Coffee also contains potassium. Soups also contain potassium. And even that salt, no, I'm just writing a brand name. Like lots of time hypertension patients, we tell them eat less salt, so they start taking this salt which is called as Luna, that is low sodium. This Luna low salt sodium also contains a lot of potassium. So potassium rich foods should be given to non life threatening mild variety of hypokalemia that would be seen in especially pediatric cases or adult cases who suffered diarrhea for a couple of days, substantial amount of fluid loss has occurred, and electrolyte imbalance has occurred. And once the potassium values go less than 3, that is when indication for giving IV correction to any patient is value less than 3. We need to upgrade. And the upgrade, again, the point is from upgrade, like it's 1.5 at admission, then upgrade would be up to, let me say, 2 point, up to a value of about 3 milliequivalents. And here again, mathematically, I can say, suppose value is 1.5 and I need to upgrade from 1.5 to 3, that would mean 1.5 into 200, that would be 300 milliequivalents. And I told you, how much can you give per day? That is 240 milliequivalents. So again, I'm not saying that be as slow as that in chronic hyponatremia. I told you in chronic hyponatremia, risk of osmotic demyelination syndrome is there. So try to be slow in correcting. But for potassium, I'm just saying that this is the standard limit which is usually advised, though this is again subject to a bit of controversy, the value that I've said. But again, I would say be judicious in administration of potassium, because anything in excess can be counterproductive for the heart as well.